So as Anne said, I work clinically. I'm a clinical academic across two institutions, the University of Hertfordshire and Eastern North Herts NHS Trust, where I am the Critical Care Recovery Service lead. So I've worked in critical care since 1998, and I thought I pretty much knew. You sort of get a little bit long in the tooth. You think you know what's happening in critical care. You feel fairly confident, and then the pandemic struck. And actually, it was a real change for us all. We really had to think about how to change our practice very quickly and adopt innovation in a very rapid sense. And I was very fortunate that my clinical colleagues embraced this as well. And from a culture where research probably wasn't foremost in people's minds, it started to become a really prominent feature of their daily lives. And I call it rapid adoption in extremis because we were forced to look at things in a different way. We started to get early intelligence. I am the deputy chair of the UK Critical Care Nursing Alliance, which represents all of the nursing organisations in critical care in the UK. We started to get early intelligence from Italy about how to care for these patients. We were very fortunate that we were getting this intelligence not only through medicine but also through nursing about how to best care for these patients. And giving you an example of proning, which is where you nurse people on their tummies to try and enhance their oxygenation. We've been using this for over 20 years in acute respiratory distress patients. And we realized early on through the experiences in China and in Italy that actually this was really important. Some early trials were taking place in Italy particularly around how to best support these patients. And we also saw tangible results in clinical practice. And I think it was that was the clincher for my clinical colleagues to really embrace this practice. We had proning teams coming in that were generally surgeons because all of their theatre lists had stopped and they were supporting. So we had essentially surgeons working as healthcare assistants, helping to turn these patients. And then we started to look at it outside of the ICU and trying to support patients on the ward and to self-prone, so patients who are on CPAP, which is a different kind of ventilation that you can have on the ward or in ICU, and then people who are just on ordinary oxygen being nursed on their tummy on the ward as well. And then the flurry of evidence was starting to come through, and we can see through in this forest plot that there's a clear mortality benefit conferred to patients who were prone. And this has started then sort of, it really gained traction and patients were generally prone. But there are consequences to some of these practices, and this also was evident. So we weren't feeding patients particularly well, so that my colleagues in the British Dietetic Association very quickly developed guidance and we adopted that into practice. In my clinic, in my critical care recovery clinic, I started to see people with nerve injuries and pressure injuries coming through. So we really needed to think about how we better cared for these patients. And I was very fortunate to be part of the Intensive Care Society Rehabilitation Collaborative, and we generated guidance on how to best support patients out of ICU. So we were able to very quickly draw together the evidence, create new pathways and put them into practice. And then we had the recovery trial, and I won't dwell too much on this because many of you know, but it was a real feat that this was up and running in such a short space of time. And in ICU, the game changer was dexamethasone. We saw a clear mortality benefit again in this population, and that really was, again, a clincher in clinical practice. So my colleagues started using dexamethasone on a daily basis, and we saw improved outcomes. And then there's the issue of staffing. So we had to suddenly start nursing a very large number of patients. We increased the critical care capacity, and we were nursing 1 critical care nurse to 6 critical care patients, supported by non-critical care staff. So again, this was a situation that we'd never encountered before, and we had to very quickly think about how to support this. Now, Professor Ruth Endicott, myself and other colleagues had got some funding through the NIHR, the National Institute of Health Research, to look at staffing. So we quickly did a pivot and thought about how we can approach this from a COVID point of view. And we started examining alternative staffing models. And we've been carrying on that work, and we're putting in for further funding to investigate the long-lasting legacy. People are not wanting to return back to the way they were practicing before, and what can we do to harness some of the positive changes. I also undertook the CLAP study with my colleague, Kath Montgomery, who is the lead on this project in Edinburgh, and we looked at the experiences and well-being of staff. And we noticed that things like learning was really important, and we've adopted things like professional nurse advocates within every ICU now in the UK to try and support ongoing well-being. We know that actually there's been sort of quite a number of changes that happen in clinical practice. And my big plea is that we would be keen to enculturate research in clinical practice. We saw the massive benefits that it brought to our clinical practice and the improved outcomes with patients. And my hope is that we can continue this work in our daily practice. So thank you. Sorry, I should have just said, I'd like to introduce Professor Charlotte Summers, who's a good friend and colleague.
Thank you, Natalie. So I am Professor Charlotte Summers, the Professor of Intensive Care Medicine at Cambridge, but I'm also an intensive care consultant whose research and clinical interest for most of the last 15 years has been acute respiratory distress syndrome. So suddenly we had a worldwide outbreak of the thing that I've spent my career working on. I've been asked to speak about innovations from the front line during the pandemic, and so I thought I would share just a few insights from the work over the last 2 years. For me, it started clinically here. So on the 12th of February 2020, it was very clear to those of us at Addenbrooke's Hospital where I practice that things were not going to be okay. We had our first multidisciplinary meeting with us as the ICU clinicians, with the public health doctors, with the virologists, with infection control, and anybody else we thought might be needed as we worked out what we were going to do to cope with what looked like a train heading towards us. And when you look back at that picture now, who could possibly imagine that we all sat in the same room, an entire intensive care team, all in the same room with not a single mask or bit of hand gel between us? It seemed just insane, but that's what happened. Then shortly after that, the whole NHS realised that things were not going to be okay, and the Secretary of State for Health issued a statement saying that they were going to need 5,000 critical care beds across the NHS. This was the 1st of March, and whilst that was enough for wave one, unfortunately we needed far, far more than that. My first involvement at national level, I guess, in the pandemic was this. It's the Ventilator Challenge programme for the government. So it was announced by the Prime Minister on the 16th of March, and like everybody else, I watched it on the news. But then on the Monday morning, the 18th, I had a telephone call asking if I'd act as one of the advisors to the Cabinet Office for this programme. And as part of that phone call, I was informed that the government and the NHS thought that we were going to run out of enough machines in the NHS to make the air go in and out for everybody who needed them. So there were not enough ventilators and anaesthetic machines in the country, even if we used everything we had to keep the number of patients we thought we were going to have alive. That's a very stark phone call to get. I will remember it forever. I also didn't think that anybody was capable of making a new critical care effective ventilator. And these were not ventilators of the type that I use in my practice all the time, but ones that were going to be good enough to keep people alive within a couple of weeks. How wrong I was. This is the lorry on the 2nd of April 2020, so 2 weeks after the launch of that programme, delivering me serial number 0001 off the production line of the Penline ventilators, coming to me for testing to see if it actually did what the manufacturer said it would. And you can see the machine that currently sits in the corner of my office as a memento of what happened. The UK manufacturing capacity managed to produce ventilators that were safe and able to be emergency use authorised by the MHRA for saving the lives of patients. Thankfully, most of them we didn't need to use, but they're there and remain there if we need them. We had to expand beds. This is a makeshift intensive care unit that we made at Addenbrooke's out of what was a medical ward 9 days beforehand. We took a medical ward and we made it into a 23-bedded intensive care unit. That sounds like something that would be pretty straightforward to do, but there were huge, huge difficulties getting the equipment that's required. And you will see that at the side of each of those beds actually is not an ICU ventilator, but it's the anaesthetic machines from our operating theatres, because that's the only ventilators that we could access at that point. We don't normally use anaesthetic machines in the intensive care unit, so that meant we had to train every single nurse and use the operating department practitioners on how to use a very different machine to usual to keep people alive. The UK scale-up for intensive care has shown how amazing the NHS actually is at innovation. If you had asked me at the beginning of January if we could ever expand critical care capacity such that we had more than 6,000 intensive care beds in the UK, I would have said you were insane. Our funded baseline in January 2020 was 3,500. We didn't have any more staff. We had to stretch everything, as Natalie described, more thinly than we ever had before. But actually, we managed to expand to the equivalent of more than 140 new intensive care units. That's the kind of stretch capacity that was needed in January of this year. 140 new intensive care units. That meant stretching the staffing, as I said. So usually to comply with the regulations and what's thought to be safe, a consultant looks after 12 intensive care patients. In the pandemic, we were looking after anything up to 30, and actually the agreement was that we could stretch as far as 60 if we really needed to. We only did that by colleagues across the healthcare sector coming to help. My own intensive care unit had orthopaedic surgeons, histopathologists, ophthalmologists, anybody we could think of coming to help, and we needed each and every one of them. We also, whilst we had lots of staff coming to help us, certainly in wave one from around the hospital, what we didn't have were the families able to come and visit. Now, in intensive care, we spend a lot of time talking with the families of our patients because it's really important. So we innovated in that space and how we communicate with our families too. This is Dr. Rowan Bernstein, one of the intensive care consultants at Addenbrooke's, who gave an interview to Sky News describing how we deployed technology and iPads in our case to every bed space in the intensive care so that we could share what was happening with the families of our patients. That sounds brilliant, doesn't it? We use technology to mean that people who couldn't be at the bedside could have some idea of what's going on. But let me tell you, the burden of telling a family that their loved one is dying via Zoom is something that you carry with you. We also had to innovate to cope with the supply chains not being as strong as we'd hoped. So there were, and these are just some examples, difficulties with acquiring the neuromuscular blockade drugs that we need to give patients general anaesthesia so that we can ventilate them when they're sick. That meant that people like the Association of Anaesthetists had to generate guidelines and produce advice about how to use drugs we had not used in decades. So I think it's fair to say that most intensivists had not used pancuronium for at least 10 years, but we used it during the pandemic. Other problem that hit us quite hard at one point in wave one is the supply lines for renal replacement therapy came within 48 hours of us not being able to provide hemodiafiltration to intensive care patients in the UK. Lots of people had different solutions for this. Ours at Addenbrooke's was that we installed SLED, so super low efficiency dialysis, into the intensive care, in fact into both intensive care units over a 5-day bank holiday weekend. We would never have been able to do that at any other time. I wrote a business case that was one A4 side. I spoke to the chief financial officer, and within 4 hours it was signed off and the order placed. Such a thing has never happened before and probably will never happen since. We also innovated for research. As Natalie said, we embedded it in routine clinical care, and this is just a timeline mapping some of the UK's response that was embedded into NHS care. So the first case in the UK of COVID-19 was identified on the 31st of January. The ISARIC 4C collaborative of phenotyping patients was launched on the 6th of February, and by the 19th of March, the recovery trial had started. By June of that year, we knew that hydroxychloroquine didn't work, and that dexamethasone did, and that another antiviral therapy was not effective. And again, the results from that work has continued to deliver. But it delivered because patients across the NHS and the infrastructure built by the National Institute for Health Research over 10 years was able to be mobilised. We had the infrastructure that we needed to deliver for our patients and to embed care for the first time across the entire NHS. research was everybody's business. Well, what has changed? Absolutely everything has changed. Some of it has been good, some of it has been bad, but none of us and nothing about the way we practice intensive care will ever be the same again.